Hi, so today's lecture is about neurophthalmology, and let's directly begin with that neurophthalm. Okay, so first of all, before starting into anything, let's talk about the visual pathway, and then we'll go into the visual pathway lesions. So, if this is the eye, okay, this is the, or let's say this is the fields, okay, the fields is in white, and now let's draw the eye in the uh, blue. Okay, so this is the eye, like a cup. I'm not drawing the complete eye. Okay, so this is the nasal part, this is the temporal part of the eye, correct? This is the nasal part, this is the temporal part of the retina, to be specific. So let me write retina. Now this is going to be the temporal part of the field, this is going to be the nasal part of the field. This is going to be the nasal part of the field, this is going to be the temporal part of the field, and here is the nose, just in case if you're wondering. So from the temporal, the rays are going to project upon the nasal. From the nasal part, the rays are going to project on the temporal. Similarly, from here, from the nasal part, the rays are going to project on the temporal, and here from the temporal part, the rays are going to project on the nasal. Let's use green for the temporal projections that we have. Okay, so green, let me just, okay, so that there's no confusion, right? So this is how it is for now. The temporal visual field is projected upon the nasal retina. Nasal field is projected upon the temporal retina. Okay, so now what? So the fibers are carried up now from the from the retina in something called as the optic nerve, and these optic nerve, they join to form something called as the optic chiasma. Okay, now that optic chiasma goes up all the way to the lateral geniculate body. So let me write here, this is going to be the optic nerve, this is going to be the optic chiasma, this is going to be the optic tract, then it reaches the lateral geniculate body, LGB, lateral geniculate body, and from there the optic radiations to the superior and inferior radiations, they go to the optic lobe or visual cortex. Sorry, they go to the visual cortex. And here these are the optic radiations. So far so good. Now let's talk about the fibers that are present. All right, let's talk about those. So let's say that from the nasal field, okay, the fibers, the rays fall on the temporal retina. Okay, so the temporal retina is here, it follows the tract, okay, the optic nerve, sorry, and it does not crisscross. Okay, it just goes, if it's in the, so this is going to be the right, or this is going to be the right for the patient. We are looking at the patient, and this is going to be the left. Okay, so the left optic nerve, or the temporal left optic nerve, is going to continue into the optic tract, okay, into the optic tract without crossing over, and it reaches the lateral geniculate body, and from there obviously into the radiations into the cortex. So far so good. This is the very basic. Okay, now here the nasal field of the right eye, okay, of the right eye, look at the right eye, looking at the right eye, cool, the right eye, the nasal visual field falls on the temporal retina, of the right eye. Okay, so far so good, understood? And that too, okay, because it's of the temporal, it does not cross. All right, it does not cross at all. So far, so what I'm saying is that the temporal fibers arising from the temporal retina never cross. They reach the lateral geniculate body, and they just reach the visual cortex. Now let's talk about the temporal visual field of the left eye. Okay, so the temporal visual field of the left eye projects upon the nasal retina of the left eye. Correct? Understood? So the nasal retina goes, it's carried forward, and very obviously something has to crisscross, so this crisscrosses. Okay, now it's not as simple as I showed. There are certain complications, but when it crisscrosses, it again goes along with the optic tract and then into the optic radiation, but now it has decussate or crisscrossed. Similarly, the temporal field of the right eye projects upon the nasal field of the right eye, and it again follows the optic nerve of the right eye of the same eye, and it crisscrosses. Alright, and again it goes into the visual cortex via the optic radiation and the lateral geniculate body. So this is the most basic part of the visual pathway. Okay, now let's see what happens on this diagram itself. Okay, in this diagram itself, let's understand what will happen in case there is a lesion at each side. So let's look at the lesion. Okay, let's look at the lesion in the left optic nerve. So the left, okay, now we'll change the color and we'll make the lesion as something like a yellow. Okay, so there's a lesion at the left optic nerve. Okay, fair enough. So when we talk of each lesion, we will draw its respective visual fields next to it or below. Alright, so whatever seems better. Okay, so lesion in the left optic nerve, talk about that. So lesion in the left optic nerve is going to affect obviously the temporal fibers of the left nerve and the nasal fibers of the left nerve. So how is it going to appear? It's going to appear simple. This is your right, this is your left eye, this is your right eye visual field. Obviously talk about the visual field. Now think of everything that's in this yellow color as the visual field. There is no vision in the left eye, and the right eye has its vision normal because there is nothing involved apart from the left optic nerve. So what is this called? Because it's only one eye, it's called ipsilateral. Because it is affecting the left eye, it's called left ipsilateral. And because it's complete loss of vision in that eye, it's called anopia. Okay. Now this left ipsilateral in anopia is seen usually, okay, it's seen usually in cases of a very prolonged optic neuritis or optic neuropathy. Okay, so the earliest one to be affected, okay, the earliest one, if I'm saying that the optic nerve, the left optic nerve is affected, the first change that is seen when the optic nerve is affected is called the variant A, or it's called the earliest optic nerve lesion. Okay, now the earliest optic nerve lesion is the lesion in the optic nerve at an early point, that is some point of the disease progression, where only the fibers that are lost, okay, are the macular fibers. Okay, because the macular fibers are the most sensitive to damage. Okay, so that is why there is first a central visual field defect, like something of a scotoma. Okay, something like this in the white, there is first the defect is out there. Okay, and gradually the scotoma, okay, we can say it's a central scotoma. So it's first a central scotoma, okay, which then becomes a left ipsilateral anopia. Okay, because it is progressive in nature, and this occurs because the macular fibers are the most sensitive. Here are the macular fibers in the center that we all know of, so they are the most sensitive, and what happens is that these fibers are usually affected. Okay, these fibers are affected. correct? So it leads to a central scotoma. Okay. What about the causes of a central scotoma? Well, the central scotoma is caused, or even the left optic tract lesion, that's the left ipsilateral anopia, is caused by optic neuritis. And optic neuritis is caused by multiple sclerosis, MS, that we commonly call. There's something called as hereditary optic neuritis, which is called as Leber hereditary optic neuritis, Leber syndrome. We have toxic optic neuritis, which is by ethambutol, ATT, antituberculous regime drug. We also have ischemic optic neuropathy. We have nutritional optic neuropathy. Let's say there is a vitamin A deficiency, or there's a Cohn's dystrophy. And Cohn's dystrophy is something called as Stargardt disease. All right. So far, sounds so good. Now, what will happen to the reflex? Okay. Now, to understand the pupillary light reflex, I have to explain another very important concept. And that concept is pertaining to how the light reflex goes. Okay, the entire pathway of the light reflex. So, what is the light reflex? First, let's talk about that. The light reflex is simple. You show light, the pupil should dilate. If you show light in one eye, the pupil should dilate in the other eye too, ideally. Okay. So, let me make the pupillary fiber that carry, okay, the entire pupillary light reflex pathway. All right. Let me make that pathway in the purple color. So let's say you've shown light, okay, and the fibers carry, okay, they carry. So they pick up the light, fair enough, and as they carry the light from, let's say, from any side, temporal, nasal, what they do is that they reach the optic nerve, okay, and they crisscross. Either they crisscross, all right, either they crisscross or they travel as a temporal fiber itself. So let me say that here there is a temporal fiber, okay, which does not crisscross, obviously. And here we see a nasal fiber because light is shown on the nasal side, and it does crisscross, all right, it does crisscross. And what happens is that these fibers, all right, these fibers do not enter the lateral geniculate body. Instead what they do is that they themselves go into a very important structure which is called as the pretectal nucleus, which is present in the midbrain. So they reach the pretectal nucleus, and when they reach the pretectal nucleus, what they do is that they relay into the pretectal nucleus, and not just of one side but of both the sides. Now the pretectal nucleus then relays on to the Edinger-Westphal, and not just one side but obviously of both the sides, correct. Now the Edinger-Westphal sends neurons. Now again, these neurons we will draw in let's say a light blue, okay. So they send neurons, okay, an Edinger-Westphal of both these sides. They send neurons to their respective ciliary ganglions, and I'm going to continue on this side because it's less shabby, okay. So it sends a neuron to your left side of the ciliary ganglion, the right side, whichever side, both sides ideally. And what it does is that it goes and it supplies the very important muscle called as sphincter pupillae. So here you've reached your ciliary ganglion and the sphincter pupillae. Now if this is clear, let me just again recap what I've just said. We've thrown light into the eye, or this eye, whichever eye, and whichever side. What happens is that eventually both these pretectal nucleuses are stimulated, and eventually both the Edinger-Westphal nucleus are stimulated, and eventually both the Edinger-Westphal give out nerve supply stimulations to the ciliary ganglion, and from the ciliary ganglion, very importantly, it reaches the sphincter pupillae and causes pupillary constriction. Now the idea is, why I'm talking about this is because when you see in a left ipsilateral anopia, there is complete abolition of the pupillary tract as well. Okay, so if there is a direct right reflex, correct? If there is a direct right reflex, it's going to be abolished, correct? And the consensual light reflex, okay? So let's say when I show light in this eye, the pupillary light reflex is not going to be present because the impulse itself is not reaching. And here there is no impulse. There is no impulse here, but here there is an impulse. So no impulse, correct? And here there is an impulse. So the impulse is present. Here there is no impulse. So that means no stimulation. Here there is an impulse, but here there is no stimulation. So therefore no impulse reaches the Edinger-Westphal or the pretectal nucleus. Correct. But let's say if I look for, okay, if I do impulses out here, if I say that there is an impulse, will there be the accommodation? Yes. Okay, that is true, because here there is no involved. Here the fibers are intact, and here you can see a certain amount of accommodation. You can see the pupillary light reflex. So if I give an impulse out here, the impulse is picked up, it goes, it stimulates the pretectal and the Edinger-Westphal, and once it stimulates the Edinger-Westphal, it causes obviously sphincter constriction out here as well on the left eye. I hope that is clear. Now once we've spoken about that, so another final statement I want to give: abolition of direct light reflex and consensual light reflex of ipsilateral eye due to damage in afferent pathway of the eye. That means if you give light reflex out here, if you give light out here, there is no reflex in this eye nor in the other, because the impulse itself is gone. Consensual, that means if I give light in the right eye or in the left eye, in this case the left eye, there will be also a response seen in right eye, but this is lost. Okay. However, the near accommodation, that is the accommodation reflex, that means if an object is present far and if you bring it close, both the eyes, their medial rectus does get stimulated, and this near accommodation is present because the near accommodation is present if one eye afferent fibers are intact. Okay, now what do I mean? It's the same concept, because this pathway's afferent fibers are intact. It goes back to the prefrontal cortex, and it again stimulates the other eye's fiber to cause this contraction of medial rectus, and obviously accommodation occurs. Now we'll talk about that again in more detail, but for now I just want to talk about two important things: the pupillary light reflex and the loss of vision. Now the important disorders as I have spoken about. Now let's see the defect in the other very important part. Let's say lesion in the central, okay, mark my words, I'm not saying peripheral. Okay, the lesion in the central part of the optic chiasma. Now if it's in the central part of the optic chiasma, you need to understand that there are two green fibers that are affected, and those are the nasal fibers. And the nasal fibers that are affected are taking supply, or they are taking vision from two parts. That is the temporal of the left and temporal of the right. So how is it going to look? out here. Let's draw it on this side. So this is your left eye, this is your right eye. The nasal fibers are affected, so think about it in this way that the nasal fibers are affected. Okay, that means this is gone, the temporal field of the left eye and the temporal field of the right eye. So that's why this is called as bitemporal, because two temporals are affected. Hemi, because half. Anopia, that means two temporals are affected. Hemi means half of each eye. Now what is it also called? It's called as temporal heteronymous because two eyes are involved. Okay, and hemianopia. Heteronymous basically means that the two eye that is involved is now in heteronymous we don't say that this is the right and this is the left. What we say, we do not say temporal nasal. For heteronymous you need to think in a more layman term. Okay, for some reason I do not understand why this new classification has come up, but temporal heteronymous hemianopia basically means, let me just get this off. Okay, this right left, this is the left eye and this is the right eye, obviously. So what happens is that here we say this is the right side, correct? This is the left side, correct? This is the right side, correct? And this is the left side. Now in a layman's term, actually this is the temporal and this is going to be the nasal, correct? This is going to be the nasal side, this is going to be the temporal. This is the actual way how we should go about. Now if it is the temporal side, we are saying it's a bitemporal because both the temples are affected. But let's say if we are not saying it in this classification, we are saying it in terms of left and right. So the right side is affected, obviously, and here that the left side is affected. So that's why we say heteronymous hemianopia. Let's say for instance, the right side was affected out here, okay, and here too the right side was affected. So then we would say it is a homonymous hemianopia. But putting the name bitemporal itself says it out loud that it's going to be heteronymous, because two temples cannot be right and right. As in, you can see it out here very evidently that if here it's a temple and here too it has to be in right and left. So it's just a stupid way of classification. I do not know why this has come across as well. Okay, so now we have two important things that we need to understand. Okay, fibers usually, if this is the vision, the fibers go down if it's the superior vision, and if this is the eye. So think about it that, pardon the entire drawing. So think about it that this is the eye and you're just seeing if the superior fibers or the superior rays go at which direction. So they go in the inferior direction, and let me just draw the eye a little longer, and the inferior, they go in the superior. Okay, inferior, this is the superior field and this is the inferior field. So if effectively even the same would be applied out here. So what happens is that now if this is the optic tract, okay, if this is the optic tract, and I hope you know that the pituitary is present below the optic tract. Now what happens is that if there is a pituitary macroadenoma, okay, and this is only seen in a macroadenoma, but before the macroadenoma would involve optic chiasma, it would have other manifestations. Okay, it would show the Stock syndrome before it would show the optic chiasma involvement. But just saying if this is a macroadenoma, a pituitary macroadenoma, or let's say there's a craniopharyngioma. Okay, now CP is above and the adenoma is below. That's all you have to remember when it comes to ophthalmology. So when CP is above, that means that the upper fibers are involved, upar wala fibers are involved, and here the niche wala fibers are involved, upar and niche. Now as I told you that the upar wala fibers are going to correspond to the inferior field, and the niche wala fibers are going to correspond to the superior field. And because that is the case, when you look at a case, okay, there are three causes of bitemporal hemianopia. One is, first of all, there is a third ventricular ganglioma because the ventricle is really close, ventricular glioma. Second is you have a pituitary adenoma, as I already stated out here in the diagram, macroadenoma. Third is that you have a craniopharyngioma, which is from Rathke's pouch. Okay. Other you can have is an anterior communicating artery aneurysm. And fourth is that you can have cavernous sinus thrombosis. Now, cavernous sinus is also somewhat out here in the lower part, correct? It's present here, very close to the pituitary, in fact. Cavernous sinus thrombosis or anterior communicating artery, which is again present out here somewhere. Or it can be due to your craniopharyngioma, which is here, which develops from the Rathke's pouch. Now, again, coming back to the point that I was trying to make, let's say we take up the pituitary macroadenoma lesion. Okay, so there is a big lesion. It's complicating it's compromising the visual field, and it's damaging the lower fibers. Okay, the inferior fibers. So the inferior fibers will correspond to obviously the superior field. And again, here we are talking about the optic chiasma only, as you can see in this V that I am trying to show. Obviously, after here there is a continuation of the track, but here you need to understand that I am talking about the optic chiasma. So optic chiasma would mean that the temporals are involved, and it's a bitemporal hemianopia. Right, left, right, left. So that would make it a temporal heteronymous hemianopia. Heteronymous because right and left is different. But now I'm just saying that the inferior fibers are affected. That means that the superior visual field is affected. So that means that the superior visual field is affected. That means that the lower part is completely gone. So what you would have now is something called as bitemporal, because both the temples are involved. Superior quadrantanopia. Instead of hemianopia, you've gone up to quadrantanopia because only a quadrant is involved. Similarly, you could say that it is a heteronymous temporal quadrantanopia or quadrantinopia. Similarly, if let's say your craniopharyngium is affected, that means that the superior fields are affected. That means the superior fibers are affected and the inferior field would be affected. So it's called as obviously the bitemporal inferior quadrantanopia. Simple. Correct. Now let's talk about the lesion in the left optic nerve or the left optic in the left optic nerve. Okay, not the central but the left. That means out here. This is the third one that I'm trying to figure out. So in the third one, it's known as the lesion of the anterior knee of von Willebrand. Okay, so let me just draw the field again because it's getting too shabby. This is the tract, and what I'm saying is that the lesion is in the left part of the optic nerve or of the optic chiasma. Now here you will think of this as a extra information, but this is how the tracks do go. Okay, so there are two fibers of nasal as well, right? Because we are talking about the nasal fibers. So the nasal fibers, okay, the superior and the inferior one, as I spoke about right now, have a little bit of a different path. Okay, so if it is the superior nasal fibers that are coming, I'm talking about the fibers, okay, and I'm not talking about the fields. And the inferior nasal fibers, the superior nasal, let me draw in blue, and inferior nasal I'll draw in red. So what happens is that the inferior nasal, he feels a little inferior. So what he does is that what does he do? He jumps up trying to enter into the other optic tract, in the other optic nerve, but he's kicked out and he's sent in the optic tract. That's how I remember that the inferior one is affected. What about the superior? The superior is superior. He does not feel anything. He just jumps into the other one. Similarly, for this eye, the superior nasal, and there has to be an inferior nasal. The superior nasal is the superior one, so he's just going to jump into the other one. But the inferior nasal feels a little inferior, and what he does is that he is going to jump up, and he's going to form something called as an anterior knee of von Willebrand. So this jumping up is called as anterior knee of von Willebrand. That's how I remember the inferior one feels inferior. He's trying to go back into the other optic tract altogether. Okay, that's how I try to remember. So what happens if that there is, let's say if there's a lesion. Now we need to get rid of all of this. Screw it actually. Let's say there's a lesion at this area where, okay, I have cut a lot. Okay, so let's say there is a lesion involving the left optic nerve, okay, along with the fibers, the nasal fibers, and the superior nasal fiber, because as it should. Actually, I feel I should draw another diagram which is more okay, so this is your field, this is your inferior nasal, this is your superior nasal of the left inferior nasal, left superior nasal. So how is it going to go? The inferior nasal is going to feel inferior, is going up, and then he's going down. What about the right, the superior nasal of the left? It's going to go straight here. Okay. What about the superior nasal out here? It's going to go straight here. What about the superior nasal? What about the superior right inferior nasal? Again, it's going to make a loop. Okay. So now if there is a lesion out here, okay, in the left optic, or sorry, in the right optic nerve, but the lower side, or if let's say it's involving the optic, if it's involving the optic chiasma, okay, as well, it's really close to the optic chiasma. So if it's out here in the von Willebrand area, what's actually going to be affected is that there are going to be three fibers that are going to be affected. Obviously, the right inferior nasal, the right superior nasal, and the left inferior nasal, sorry, because of the knee coming in. So now the fibers are affected. So if you think about it, if this is your left eye, this is your right eye, the right inferior nasal is affected, the right superior nasal is affected. Okay, the right inferior nasal is affected, the right superior nasal is affected, and also obviously the very important tract that we have is the temporal tract, right? So the temporal tract is also going to be present out here, and it's going to go here. The left temporal tract is going to go in this left optic radiations or left optic tract, and the right temporal fields, the fibers are going to go in the right optic tract. So the temporal is also going to be affected. So the right temporal is also affected. That means literally the temporal and nasal is affected. But the point that I'm trying to make is that there is one extra fiber that has been affected, that shouldn't have been affected, and that's called the left inferior nasal. And left inferior nasal fiber is going to correspond to the temporal field of the superior part. So this is how it looks, and this is called as junctional scotoma. Because of the junction out here formed by the inferior nasal fibers, a defect is seen. Correct. And what is the cause of this? The cause is a meningioma. Okay, so this is done. Also, what we can call it is a superotemporal quadranotopia. Okay, but I think junctional scotoma is the best way of representing this lesion. Now let's look at another lesion that we saw. Let's go again back to our main diagram, and the fourth lesion that we want to look at is the lateral part of the optic chiasma. Now that is literally involving. Now the third one was this, and up a little more higher into the optic nerve. But the fourth one is the optic chiasma, but the lateral part of it. Okay, the lateral part of it. Fair enough. Fair enough. So the lesion in the optic lateral part of the optic chiasma is basically involving these fibers. So let's look at the lesion in the lateral optic chiasma. Okay, this fiber and this fiber. That means that the temporal fibers, the left temporal fiber, the right temporal fibers. Correct? I hope you've got that, and I hope it's easy now to understand. So what's going to happen is that there are going to be two visual fields. The temporal fibers are affected. That means that the nasal field of this is affected. The nasal field is here affected. Right, left, right, left, left, right affected. So what can we call it? We can call it binasal hemianopia. Okay. Or bilateral nasal field loss. Okay. And this is one of the rarest visual fields, I feel, because the causes are going to be something of an hydrocele or hydrocephalus, not a hydrocele. I'm extremely sorry. And primary empty sella syndrome, because if the sella is empty, CSF accumulates. Okay, so CSF is basically compressing the lateral part of the fibers. Correct? And the way the brain is kind of visualized is that this is the stalk, okay, and this is the pituitary, okay, and here somewhere you have the optic tract, and here you have the corpus callosum, okay. And here, literally here is the fourth ventricle, and because it's the ventricle, we'll draw it blue. However, it's not even close to being blue. And here is the connection with fourth ventricle and continues down, obviously. Now what happens is that if there is a hydrocele, there's increased pressure. And increased pressure is basically compressing the lateral part of the optic tract. So if I am to draw it in this manner, okay, what happens is that there is a third ventricle that's present very tightly or very closely around the optic tract, okay, very close. And if that is having a hydrocephalus, obviously there can be compression. So that's one thing, and that's very rare. There has to be a very high level of hydrocephalus that should be present to see this. Okay, so that is about the bilateral hemianopia. Now let's look at another very important lesion that is present. A very other important lesion is lesion in the left optic tract, or even in the geniculate body. It's almost the same. All these fibers are at left optic tract or geniculate body. Simple. You know what fibers they are carrying. They are carrying the ipsilateral temporal fibers and the contralateral nasal fibers. That's basically it. So because it's the ipsilateral temporal fibers that are affected, okay, because it's the I'll draw it out here, okay, it's this fiber and it's this fiber that is there present, right? So it's gone. So that means that this is the nasal and this is the temporal fibers. That means these are the nasal field and this is going to be the temporal field, correct? So what's going to be lost? Obviously the nasal field is going to be lost, and here the temporal field is going to be lost. So now you can say right left, right left, right left. So now you can say that this is what we can say is that this is a contralateral, okay, this is a right sided, because this is a left sided contralateral, okay, homonymous hemianopia. Why contralateral? Because different eyes, obviously. Okay, so this is a right sided contralateral hemianopia. And what are the causes of it? The causes of it are, we can say that the causes are TB, syphilitic meningitis, posterior cerebral artery aneurysm, something like that. And we'll continue upon this, or let me just clear one more very important thing, is that from the left lateral geniculate body, we know that there are two radiations that are going, correct, that I've shown in this main diagram, is the superior and the inferior radiation. The superior radiation passes through the parietal lobe, the inferior radiation passes through the temporal lobe. Now the point that I'm trying to make is that if it passes through the Mayer's lobe, that is the inferior temporal lobe, okay, the fibers affected are, if the inferior fibers are affected, okay, the ones that pass through the temporal lobe, the fibers affected are obviously the ipsilateral temporal fibers and the contralateral nasal, but the inferior fibers are affected, correct? So that means that the superior visual field would be affected, just like that we saw right now when we were talking about the optic chiasma, okay, the central part. If the inferior fibers are affected, the superior visual field is affected. So similarly out here, in this case, in case number whatever 6, 7, I don't know, what happens is that because the contralateral temporal are affected, the ipsilateral temporal field is affected, temporal field, and the contralateral nasal field is affected, but the inferior fibers are affected. That means that the temporal, let's say we are showing the right one, okay, the right one is gone. So the nasal field is obviously affected. We are doing the inferior one, so sorry. So the superior field would be affected, and that basically means that the lesion is going to affect the superior quadrant of both the sides, okay, because here you're going to have temporal coming and here the nasal, and the nasal is going to come obviously from this side. So fair enough, right? So let me just draw that again. This is the temporal field, this is the visual, this is the temporal fiber, this is the nasal fiber corresponding to the nasal field, here the temporal field. So the loss is going to be simple. Here is the nasal field, here is the temporal field here that we are talking about. So the temporal field is loss and the nasal field is loss. So this is how the inferior and the superior radiations differ. Well, if it was the superior radiation, it would be the same case, but the lesion would be something like this. Very simple, as simple as it gets, okay? So we call this as pie in the sky for the first case, if the inferior fibers, that the Mayer's loop is affected, and it's called pie in the floor or on the floor when it's the superior fibers that are affected. And the technical name, okay, is called right-sided. Okay, let me just make not right-sided, this is right, left, this is right, this is left. So this is going to be the left-sided contralateral because 2, inferior homonymous because the same side, quadrant shinopia. And similarly this would be right left, or you could have said as, because see now if it's nasal and this is temporal, so we cannot say nasotemporal or something like that. So what we have said is that we say left, correct, left-sided homonymous superior contralateral because 2 eyes, the other eyes, quadrantanopia. And that is about it when it comes to the different lesions, okay, the different lesions that are present. And now let's look at the lesion that involves the visual cortex directly. Now we've got the visual cortex, okay. If the visual cortex are involved, okay, lesion in the visual cortex, so what fibers are destroyed? That's the question, right? So the fibers, let's say, is dependent upon how the visual cortex is affected and which side, okay. So if this side is affected, that means this is the left, so the left temporal and the right nasal fibers are destroyed, okay. So again, what you will have is that you will have something like this: your two eyes, left, right. Your left temporal is affected, that means your left nasal field has to be gone, correct. And your right temporal are affected, that means your nasal field has to be affected, correct. So that depends upon where your location is, okay. That's all I'm saying, that it depends upon where your location is, that which side of your visual cortex is affected. All right, because as I said, that the right nasal is affected and the left temporal is affected, temporal fibers, correct. So that means that the nasal and temporal fields are involved. That means that the nasal and the temporal fields are involved, okay. So if the left temporal fibers are affected, that means the nasal fields are affected. If the right nasal field is affected, that means obviously your temporal field is affected. I don't know, for some reason I drew nasal and I thought only there's something wrong, correct. So then it is called as right sided, because this is going to be a right, this is going to be a left, right, left, right. So it's going to be a right sided contralateral, correct. Right sided, it's going to be contralateral homonymous hemianopia. That's it. Again, the same as we saw in this bombs radiation, nothing very difficult. But now it comes where, what is the sparing, what is spared when we are talking about the posterior cerebral artery, okay. The posterior cerebral artery is supplying the lobe, okay. The lobe, that is the visual cortex, is supplied by the posterior cerebral artery. Now, if this posterior cerebral artery is infarct, only the central part has also supplied by the middle cerebral artery. So sometimes what happens is that the lesion is present, okay. The lesion is present everywhere else, okay. So the tip of the visual cortex, if the tip of the visual cortex, okay, are affected, then only the macular area is affected, correct. But if the tip is not affected, that means other parts are spared. So what is more susceptible? The tip is susceptible, or is the other area susceptible? Where the tip is also very susceptible, okay. So when the tip is susceptible, okay, you have to think about it in this manner, okay. Let's say if the tip is gone of the middle cerebral artery, what's going to happen is that there is only going to macular area is going to be affected. That means instead of the entire thing being affected, only this much would be affected, as I'm showing in the red. All right. But let's say if the posterior part is affected, then it would literally posterior cerebral artery is affected. It would literally mean that the central part is spared and it would give a cookie cutter appearance. It's called cookie cutter defect. This one is called cookie cutter defect because the small cookie cutters. And what are this called? This is called macular defect. You just have to say a macular defect. And when you're saying that there is sparing of the macula, you have to say hemianopia with macular defect, because everything else is literally the same as we saw in the lesion in the visual cortex or the fibers as well, correct. And I think that is about all the fibers that we have covered. Thank you very much.